I'm Curtis Robb. I'm a clinical lecturer here at the Royal Orthopaedic Hospital, and today I'll be running through the foot and ankle examination. We have our patient, and it's important to begin with inspection. Assess if the patient has any walking aids. Have a look at their shoes for patterns of wear, their spine for any evidence of a spinal deformity or a hairy patch which may indicate a spinal dysraphism, and the legs for the overall limb alignment. Sarah, could I ask you to stand up, please? For the leg alignment, you should look for any varus or valgus. You should then ask the patient to take a few steps so you can have a look at their gait pattern. Would you like to do that for me? When this is done, you should look to see if they have the three rockers of gait, which are heel strike, mid stance and toe off, ensuring that they are symmetrical and even throughout. I'd like to stand here for me, please, Sarah. You should also then assess the foot in a functional weight-bearing position, having a look at the overall foot alignment, any signs of pes planus or cavus by assessing the medial longitudinal arch, and the forefoot alignment for any hallux deformity and any deformity of the lesser toes. Of course, you should always assess for any scars, swelling or erythema. You should then assess the patient by looking from behind with them facing the wall. Sarah, would you like to do that for me, please? In this position, you should look at the calf musculature to assess for any wasting. You should also look to see if the patient has the too many toes sign. Normally, from the back of the ankle, you should be able to see two lesser toes. Any more than this may indicate a posterior tibial tendon dysfunction. You can then ask the patient to perform a bilateral heel raise. Sarah, could you do that for me, please? In this position, the heel goes from a normal valgus attitude into inversion, hindfoot varus. And you can see in this case, if you go down again and then back up, the heel goes from valgus into varus. You should then get the patient to perform this by a single heel raise. Could you do this on your left leg, please, Sarah? The heel goes from valgus, if you go further, and it goes into varus. And again on the right leg. Any problems with this may indicate either a neurological, a muscular, or a posterior tibial tendon dysfunction. You should then ask the patient to take a seat and examine the foot and ankle more closely. It's important for any orthopaedic examination to continue with the theme of look, feel and move. Taking a closer look at the foot, you can assess for scars, swelling, subluxation of the lesser metatarsal heads, signs of a bunion or indeed a bunionette. You can also assess between the toes for any ulceration or callosities beneath the foot, at the forefoot, underneath the first metatarsal head or the lesser metatarsals. Callosities in the midfoot and the hindfoot, and these will indicate the pattern of gait. You should then ask the patient if they're painful anywhere and then move on to feel. Feel around the tendo Achilles for pain. Feel around the peroneal tendons, the lateral malleolus, the lateral ankle joint line, the anterior ankle joint, the medial ankle joint, the medial malleolus, the posterior tibial tendon down to its insertion, the plantar fascia area for signs of plantar fasciitis, the sinus tarsi beneath the lateral malleolus, the base of the fifth metatarsal, the extensor tendons over a prominent bunion, beneath the lesser metatarsal heads, or over a bunionette. Should then move on to assessing the range of movement. This should be done from a proximal to a distal direction. Assessing the ankle range of movement. It's important to distinguish between the ankle and the mid-tarsal movement. You should assess dorsiflexion and plantar flexion. You should then assess subtalar movement by stabilising the talus with one hand and then moving the hind foot to inversion and eversion. The mid-tarsal movement can be assessed by stabilising the midfoot, placing the foot into adduction or abduction. The first metatarsal movement can be assessed by again stabilising the midfoot and depressing the first metatarsal. You can also assess the range of movement of the hallux and the lesser metatarsals. Moving on to assess the tendon function. The posterior tibial tendon can be assessed by getting the foot into a plantar flexed and inverted position. Here you can see that the posterior tibial tendon is working nicely. Explain to the patient to hold that foot in that position and hold it like stone. You can then resist pressure on the medial side of the foot whilst palpating the tendon, and this will give you an indication of the posterior tibial tendon function. The peroneal tendons can be assessed by getting the patient to place their foot in a dorsiflexed and everted manner. This will then show you the peroneal tendons. Again, get the patient to hold their foot like stone and resist your movement. You can then palpate the peroneal tendons and assess their function. Similarly, the tibialis anterior can be assessed by asking the patient to dorsiflex the ankle and invert. Again, you can see the tibialis anterior tendon working nicely. Explain to the patient, hold the foot like stone, don't let me move it, and you can get a good idea of the tendon function. Ankle instability can be assessed by the anterior draw test. This is performed with the foot relaxed and in a plantar flex position. One hand should be used to stabilise the tibia and the other hand to draw the hind foot forward. This will indicate the competence of the anterior talofibular ligament laterally. The lateral ligamentous complex can also be assessed by getting the patient to invert the foot, and you can feel the lateral ligamentous complex just beneath the lateral malleolus. Any excessive opening up of this site may demonstrate incompetence. Any signs of osteoarthritis at the first metatarsophalangeal joint can be assessed by the axial grind test. This is a painful test, so you should be careful and always check the patient's face whilst performing it. You axially load the hallux and grind the first metatarsophalangeal joint, assessing the patient's face to make sure that they're not in undue pain. This will be an indication of hallux rigidus. You can also assess the tendo-Achilles function, and this should be performed by doing Simmons manoeuvre. The patient should be prone, and you should have the foot in a relaxed manner. You should then passively squeeze the calf muscle, and you should see plantar flexion of the foot, provided the tender Achilles is intact. Should there be a rupture of the tender Achilles, the foot will not plantar flex when the calf is squeezed. When the calf is squeezed, you can see here the tender Achilles is functioning as the foot is going into plantar flexion. Finally, if you do have a patient with a pes cavus deformity, in all likelihood they will have a hindfoot varus abnormality. The flexibility of this can be assessed with the Coleman block test. Here again we have our patient with a hindfoot in varus. You then position the patient on a wooden block and allow the first metatarsal head to be depressed, and then you can see that the hindfoot goes from a varus into a valgus position, and this indicates that the hindfoot is flexible and there's movement at the subtalar joint. As with any orthopaedic examination, you should always assess the vascular and neurological status to complete your examination.